I am really excited to introduce one of the co-chairs of the conference this year, Dr. Carolyn Chu, who's the principal investigator for the National Clinical Consultation Center of the AETCs and a professor of clinical family community medicine at UCSF. She's going to be talking about the top 10 questions that the AETC National Clinical Consultation Center Warmline receives.
Hi, everyone. Thank you so much. I am just really honored to be part of today's afternoon session. Appreciate everyone who's still here. I'm just going to say this is the session where everyone can just relax. You don't need to take notes. You don't need to worry that you're going to miss a detail, which is how I was feeling at the OI panel. And really, I think, hopefully, what I'll be able to share with everyone here is just sort of like, what are the types of questions and themes that are emerging from providers across the country? And some of these kinds of questions might really be resonating with you because you are the local expert. You are also getting these questions, or they may be, not something that's necessarily being observed in your community of practice yet, but maybe for others. And so, it could be that this, these are things that are just starting to bubble up. I think we're in a really unique position to, hear about, not only the zebra cases, but also help to identify what are the ongoing kind of needs and gaps that may be happening across the country. So that's why I'm here. All right, I have no disclosures. Here are my learning objectives. There are going to be a couple of themes that I really do kind of want to focus in on. I think because, again, you all are the experts or, growing in to become the experts. And I think there are some areas of HIV medicine that I'll just say, we haven't maybe been having as many conversations around that I think for me are just real areas of my interest. And I think that these are things that we need to keep paying attention to. And certainly you'll hear me go through some of these, especially when it comes to, the gray zones, the diagnostic challenges, things of that nature. All right, so let's go ahead and just do a couple quick audience response questions. So for people who may have a false reactive initial HIV screen, just want to hear from you. What do you typically go to as your next step? And all of the above is not an option. Thank you for the peppy music after lunch, whoever's controlling the music. All right, let's go ahead and see. Great, so I'm seeing that about almost 3/4, okay, now it's closer to 60, thank you, are folks who would really want to get more of that clinical context. So you want to ask about recent exposures, vaccines, PrEP or PEP use, thank you very much, or just any type of acute illness that might potentially just, be an explanation if this ends up being a false reactive screen. Great, and I do also appreciate, though, that we are hearing a lot about rapid ART initiation, and I agree that, when we have multiple steps to our HIV diagnostic cascade, to me, I think the question of rapid ART or no is a very, very relevant one. And then we do see that some folks will do something else, and then also that on that same day that you offer rapid ART, you would also be drawing labs. Great. All right, so second, 2 of 2 audience questions. So, and again, I'm not going to go through this too much because I think Dr. Havens did an excellent job sort of really touching on all the questions that are coming up around LA ART. But in a person who has already been switched to Cabril from a suppressive oral regimen, and now see they have gotten doses 1 through 4 on an every other month schedule, but now they have a viral load under 200, specifically it's 190, what would you do? All right, let's see. Okay, all right, so a lot of folks would understandably want to recheck a viral load, and then also it looks like there's a lot of interest in the DNA genotype or PUMC. The trade name I've heard many folks mention is sort of, that archive genotype. So I see that people are really gravitating towards that option. Some folks would say, you know what, it's 190. I learned from the Ryan White Clinical Conference that I'm not going to get too worried unless it's over 200. I'll just, move forward as we've been doing without any additional intervention. Some folks folks, again, because of the rich discussion that we heard earlier on the long-acting panel, they might actually try to take advantage of maybe some of the PK data and back down to a monthly schedule. And then 1% would say something else. Great, thank you. So let's just go ahead into my talk. Now, I do have a couple of just sort of intro slides just describing a little bit more about the NCCC and specifically also the AATC program. As Dr. Cheever mentioned, we are actually part of this really, really robust network of local and regional experienced trainers. And I think if there are folks here who have not yet had an opportunity to connect either with your local or your regional office, I would say please go ahead and do that. They know really how the HIV workforce is changing very rapidly. You know, there could be one clinic that has an HIV expert who is now retired, and so even like who are our local champions is really a question that comes up from time to time. So please, 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 if you haven't already connected with your AATC, please let them know that you're a resource to them and that you may be also training people who want to hear from them about the content that they've developed. All right, that's my plug. All right, and we're part of the AATC program. So again, I think to understand the type of questions and sort of appreciate the variety of questions coming to our lines, it's actually important, if you'll indulge me, to just share a little bit about our history. So our NCCC was actually born 30 years ago. I currently work at San Francisco General, and basically in the early 1990s, you know, this is really when the cases of very, very severe sort of presentations of advanced HIV infection were really popping up mostly in the inpatient setting, right, in the ERs, and it was just a really sort of scary, you know, mysterious entity. And ultimately, this was a lot of, you know, grab your colleague. This is sort of where this hallway, you know, curbside consultations started coming up. And ultimately, this was like phone a friend before mobile phones. So, you know, really, I think there was this need that we saw very, very starkly in San Francisco. And then ultimately, you know, it's like, well, San Francisco can't be the only area, right, like that's grappling with this. And through really the sort of generous support of HRSA, the NCCC was sort of embedded and incorporated into the AATC program. So I do have cards if folks, you know, want specifically some sort of hard copy materials to pass out in your clinics. But basically, as you can see here, we have actually grown. So not only do we have an HIV Warmline, but we also have the 24/7 perinatal HIV hotline. We've got our PrEP line. We've got our PEP line. We are also firmly embedded in the sort of syndemic space as well. And so we do also take calls around substance use and Hep C, which I'll also touch on briefly as I go through some of the common questions. All right, so just I can't be up here and not say a word about HIV workforce. This has been a topic that's been near and dear to my heart, honestly, since residency. And I just thought it might be interesting to just share some of the data. So when callers call us, we do ask them just to give us a little bit of a sense of what their practice and what their experience looks like. So we do see that, and this was, I think, like a 4 or 5 year, you know, snapshot. But basically, a little bit over half of our callers to our HIV Warmline indicated that they've actually been in practice for less than 10 years. However, half are actually working at clinics that are doing a lot of treatment for people living with HIV. And then if I sort of walk you over to the bottom part of it, you know, half of our PrEP line callers have been in practice for less than 10 years. So I think, you know, there is a kind of a divide that has just, you know, come up around sort of who's prescribing PrEP or who's really delving into HIV prevention, and then the folks who are treating. And I would love to say that I think we need to sort of firm up those connections between those groups of providers. All right, so let me just get to my 10 scenarios. I am gonna try to have sort of a little through line and a little bit of transition from each to the next, and hopefully, and certainly, you know, folks are welcome to ask any questions, because I'm not actually gonna touch on, you know, sort of go into deep detail with each of these. I just wanted to, again, give a sense of the types of calls that are coming up and my own sort of personal reflections around those. So let's just start off with PEP, or post-exposure prophylaxis. So our PEP line is our most, you know, highly utilized line. We are taking questions about occupational PEP. We're also taking questions about non-oc PEP. So we have a lot of experience with PEP and thinking about PEP. And so I think the pearls that I might just sort of offer and start off with is, PEP has been around for a long time. And I would say probably up until the last couple years, it hasn't been too active an area of scientific inquiry. And I think it would be great if we could sort of bring PEP into these conversations about PrEP that we're having, because I think it's time, right, to take a sort of a renewed, refreshed look at PEP. And what we hear about is that people often get stuck in this zone that I'll call the risk assessment zone. Right? We talk about what's the risk of PEP. We talk about what's the benefit of PEP. We ask for questions about, well, tell me more about the needle stick. Tell me more about this exposure that you had. Tell me more about the person that you were with. And ultimately, I think what I am really appreciating now is that sometimes when we anchor a little bit too much on this, what's happening is that people are actually experiencing delays in initiating their first PEP dose. So our team was actually able to sort of pull about 10 years of data from our occupational calls, and that pattern really was very striking for us. We are going to be looking at our NPEP data as well, but I frankly would not be surprised if we're also finding that there are some delays in that initial PEP start. And I think this is a reflection of the fact that people are accessing PEP in different places. Maybe the initial person who does their blood work isn't the person who's going to feel comfortable prescribing their PEP, and it's also not going to be the same person who sees them in follow-up, right? And so I think PEP has just gotten harder than I would say it probably needs to be, and I would really advocate for us to kind of start streamlining things and really working with our colleagues to tell them, hey, these meds are really, really safe. Yes, you do need to be aware of a couple of counseling at points when it comes to prescribing, but you know what? You need to start the PEP, and then a little bit later, once we know you've started it and we've gotten the rest of the information, then we can have a second discussion about whether you want to continue PEP, right? And I think this is sort of one of those details that maybe has sort of gotten lost in the data, or because it's frankly pretty old data. But the way that we think PEP works is that it's really blocking those initial steps of viral replication that are happening locally before the virus has had a chance to really sort of establish itself and get into someone's entire system. And so this is why it's so important that if you were wondering about PEP, you just want to get that first dose on board. And I think, yes, there might be many, many people who don't end up feeling like they need to or want to take the full 4 weeks, and that's okay. But if we've lost an opportunity because we've told them, I can't prescribe this for you, you got to go to the health department, it's a Friday, you're not going to be able to see them until Monday, to me, that's a lost opportunity. All right, so this is sort of my last slide on PEP, and then I'll just wrap it up. Really, the initial PEP evaluation can be kind of distilled into this simple principle. Was there potentially infectious material? Was there a portal of entry? If it's yes, that's a potential exposure. You can, talk about the meds, let them know what to expect. Make sure that you're doing that sort of safety assessment to see if someone has pre-existing kidney disease or maybe an elevated risk for it. But I would say this is the group of providers in this country that is going to feel, I would, say, you should feel comfortable, right, prescribing these meds, or at least letting your colleagues know that they can, and if they can't reach out to you for questions, they can reach out to us at the PEP line. The other point that I'll just really say here is that I think we should really be, again, leveraging some of the successes we've experienced with PrEP and really add PEP into those discussions as well. So we know that there are transitions between, folks who have been prescribed PrEP, maybe sort of, got lost to follow up with their PrEP clinic, had an exposure to they didn't have any PEP in pocket, right? And so they are seeking an urgent, time-sensitive evaluation. And so I think, there's a lot of the sort of integration of PrEP and PEP that we could be doing. All right, so on to the second sort of common question. I'm really happy that I'm not giving any talk up here about, okay, PrEP or no PrEP, right? But really, we have multiple options now, and I think the discussion has actually shifted slightly. So we're saying, okay, well, it's actually about which PrEP. And so I'm just going to be talking a little bit more about this today, and so I'm not going to, go into too much detail. But again, I think, one of the common questions we get on our PrEP line is, hey, are these side effects due to PrEP? Are these LFT, is this LFT bump due to PrEP? And yes, there's our prep line, but we have beautiful, beautiful toolkits that are readily accessible. David Spock's team has built a beautiful site for prep curriculum. There's an app that goes along with that. There are many, many sort of capacity building groups that have really put a lot of care and effort into developing a lot of materials to make us all feel really comfortable about sort of stepping into this prep space. And so, my take-home point is really the best prep option, right, is the one that's going to be working for that patient. And I will say that we actually get a lot of calls about cases where someone's prep prescriber actually told them to stop or discontinued it because there was some concern, and it's really easy to kind of say oh, well, it's the prep. So even though the provider-initiated discontinuations might not be happening a lot, I can tell you that they're still happening. And what's sort of unfortunate is that it's this kind of black or white, well, you just can't be on prep, which isn't really going to be the case, right? We've got many options now, and I think I would also just sort of beseech this crowd to really help us close those gaps. And then again, you'll hear about it a little bit more today, but really I think we're hearing the message loud and clear. Prep use is very dynamic. People will change or stop and start prep for various reasons throughout their lifetime, and it's okay. It might make us nervous, but it's okay. Certainly for people who are newly initiating prep, there are many, non-invasive supportive interventions that we could be sharing information about that might help someone feel more comfortable staying on that prep that they just started. But then really, if you are seeing renal concerns, if you are wondering, okay, I have this AST bump, what should I do? I'll say that we also now have more options to know, really, how are we going to safely manage patients without stopping that prep agent? And we get a lot of calls about LFTs and prep, and I'll just say this. Even though you don't have to do LFTs per se, right, I just think a person is coming to us to seek care. I mean, liver health is so important, as we've heard from multiple speakers here. And so if you are affiliated with a prep program that is able to offer vaccines, is able to offer Hep C treatment, I just think that sort of one size, or the sort of one stop model, I think could really be appealing to many patients. And really, we want to make it as easy as possible for as many people as we can. All right, so I'm going to just transition a little bit into talking about testing. This is an area of sort of HIV medicine that is personally of interest to me, and we had a breakout earlier during the conference on it. So we get a lot of calls about cases where the provider, who's sometimes the PCP, but again, sometimes it's the HIV expert, saying, am I looking at a false positive or false reactive test? Oh, I remember back in residency, I learned that, a certain proportion of the population of people with HIV, they're elite controllers or elite suppressors, or is there just something new going on? Why is my lab trying to make me crazy, right? So I will just say false positives do continue to occur. People might have felt like they sort of saw a bump with, COVID or even vaccines, and they do just still occur, probably more often than any of us would be comfortable seeing. And it can happen for many reasons. There are interfering antibodies that could be sort of causing some cross-reactivity on those initial serologic screens. There could be laboratory mix-up, sort of specimen contamination. Again, that's happening more often than we want. And I'll just say, for researchers that are in the room, I think the initial bolus of kind of scientific or data that we had around elite suppressors, it's like 10 plus years old now, and I think it would actually be really interesting to kind of relook at this, because I have spoken with some people who feel like there may be certain geographic regions that might have, sort of slightly higher prevalence of elite controllers compared to if we were looking at it really sort of with that national population lens. The other thing that I will go into a little bit more often is that you will be seeing cases of people who may have seroreversion. Perhaps they were started on antiretroviral therapies very shortly after they acquired HIV. We've also seen cases of people who have this sort of sero-waffling phenomenon, which is that you test them on one day, you'll see antibody, you test them on another day, antibody's non-reactive. And I think for us also, you might be wondering, why is there a case report from the Green Journal? Pregnancy. this is an incredible opportunity for us to intervene by increasing our screening, making sure that that screening is done in a timely and integrated fashion, because we know that if people who are pregnant, if their HIV infection can be identified early in their pregnancy care, and if they can, then be offered treatment early and then suppress on that, we are potentially saving 2 lives, right? And so what's happening is that, some folks are not necessarily super well engaged in antenatal care. They could be getting their outpatient prenatal care in one clinic, and then they show up at another hospital that doesn't have access to those records. And a lot of times people are being offered rapid testing on the labor and delivery units, right? And so there's a whole host of decisions that have to be made at that point that are impacting mom's care and that are impacting baby's care, and it is not easy. So I'm going to guess that most folks are pretty familiar with this algorithm that was put out about 10 years ago from the CDC, so I'm not going to go through this too much, but I just want to call your attention to last year, there was a technical update that was put out, and I don't know if you know if your reference lab has made the switch or not, but just know that some labs, instead of going to the differentiation as their second step, they're actually going straight to a differentiation NAT. Okay? And if they have gone to that step, you're not going to see the differentiation antibody that you might have been expecting before they went to this change. So just know that they're testing for a different target. The report to you is going to look different than when it, was prior to that switch. So it might be worth making sure that what algorithm your lab is following. There's another alternative as well, again, for labs that don't want to go to the differentiation anymore. They just go straight to the HIV-1 NAT, so no 2, they just go straight to the HIV-1 NAT if the initial antigen antibody was reactive. All right, I'm not going to go through this, but this is just all to say there's lots of different platforms that are available right now. These are all the laboratory or instrumented assays, so drawing blood, sending it to the lab, running it on the instrument. This is not a visual point of care. And as you can see there is some overlap, right, in the target proteins that these labs are designed to detect. But what we don't know is that the algorithm that gets programmed into the computer to then tell the machine what result to share post on Epic is an algorithm that's proprietary, and ultimately, depending on sort of how intense a signal it was at whatever protein level, that's how the lab tells you whether it's non-reactive, reactive, or indeterminate. All right, so again, this is just all sort of a long way of saying I think it's really important for all of us to be very familiar with the technical aspects of HIV testing. We thought maybe it was just like, yes, this person living with HIV, no, this person is not. But you're going to get the indeterminates. You're going to get the people on PrEP who you have no idea what to do, how to interpret the result. I think it's really important to set up those connections with your reference lab. Not everyone has the benefit of getting a signal to cutoff ratio from your lab, but if you do, it could be very helpful to get those details. And then also, not as many labs, but certainly some might be able to give you actually exactly which band pattern was lighting up on the machine, and that maybe could be informative. And again, we are widely rolling out rapid PrEP, right, or rapid ART. If someone has an initial reactive 4th gen, you're going to get the question, should I start them on BIC/F/TAF or not? Even before you've had the results come back of those additional steps. So again, just sort of putting everyone here on alert that this is going to happen. And ultimately, because we don't have sort of widely available super sensitive tests right now, I have a very low threshold to just repeat testing in a couple of weeks, potentially on a different platform if my lab's able to do that for me. All right, is this a breakthrough infection on PrEP? I sort of alluded to this earlier, and I think we'll hear more from Hamid about this, but just know the Levi syndrome's gotten a lot of visibility, as it should, but I just don't want us to forget, we actually were hearing of cases of ambiguous testing for people who had been on oral PrEP. And I do feel that as more people start and stay on oral PrEP, we're gonna be hearing more about these cases. And again, this is one of the reasons to me that I feel like HIV testing is just so important for us to be very comfortable with. This is just a screenshot of a review paper that was written a couple years ago that I think sort of nicely sort of depicts the subtle differences in the dynamics of what we will see on the tests that we have available to us. All right. Certainly, if folks are interested, I'm happy to take any questions later on, but our team at the NCCC, and specifically the PrEP line, is involved in a research collaboration involving some folks at CDC who are very interested in this issue, and then also the SeroPrep study team, which had been just an established research group at UCSF. And so the SeroPrep team is able to offer very, very, very comprehensive testing and follow-up under research protocol. So if you think you might have a case of someone with unclear HIV status on PrEP or clear sort of has acquired HIV, give us a call at the PrEP line. If you have any clinical questions, we'd be happy to talk you through the options. Or if you don't need a clinical consultation with us, but you just want to go straight to the SeroPrep team, that information is there, and you can certainly scan their QR code. All right. Which ARV should I start for this infant? I will be going through this in a little bit more depth in my breakout later today, but just to say, if you are doing women's and children's health, and certainly if you're staffing the hospital, please, please, please become very familiar with these guidelines, because they are getting updated very quickly as new, sort of experience and evidence is emerging. This is just a screenshot from the sort of most recent guidelines, and just to say, everything that's in yellow was new, right, at the time of that update. And we are anticipating these to be updated again in the next several months. And so the way that the current guidelines are laid out is they try to do this, risk stratification, right? But ultimately, the most information that you can possibly get about mom's HIV treatment, her response to treatment, what her viral loads are, that is what you need to make a decision that you can feel really confident about for the infant. And again, this is where testing in pregnancy is so key, because as the current guidelines say, if someone has come into L&D and they have a reactive HIV, you're potentially starting that baby on triple ARVs, right? Because you're assuming that this is a person who has untreated HIV infection until you can get the rest of the information telling you that is not the case. All right, so other considerations and pearls, life, we can sort of make the best laid plans, but obviously stuff just will happen. And I'll say there continues to be this, kind of association between HIV or ARTs and preterm delivery. We do not know, what the mechanisms are yet, but this is just to say preterm deliveries among women who are living with HIV are really, really common. And again, as the current guidelines state, we don't have established dosing recommendation for 3TC or lamivudine and nevirapine for infants that are delivered under 32 weeks. And this is a real hard space to sit in if you're a managing provider and it's, a mom who has not yet been able to suppress on treatment during pregnancy, baby's 30 weeks. You really kind of only have an option of AZT, and that doesn't feel good when you know that mom, has been experiencing viremia even in the weeks leading up to that unplanned delivery at 30 weeks. So I would just say, this is sort of a good lesson for life. Just expect the unexpected, right? If you're at a delivering institution that's fairly high volume, you just want to make sure that you are connected with your pharmacy colleagues. You want to make sure that they have the meds. And if they don't have the meds in stock on formulary, that they have a plan B when this baby is delivered at your hospital. And you can always call our perinatal hotline. All right, my patient is interested in breastfeeding. Is that okay? I was really pleased to see that I think everyone really here is aware of this huge important shift in our approach to this question in the US. And so again, the current guidelines, as they state, is that we should be offering patients person-centered, evidence-based counseling to support the decision that they desire for how they want to feed their infant. There are a lot of questions that we are currently still facing as we go into 2025. We don't yet know, who needs to be on the team, right? On the prenatal side, on the postnatal side. What about cell-associated HIV? This was brought up in one of the panels. There are cases of moms who have been suppressed at delivery, who then we found out later infant was diagnosed. We still have lots of different options for ARV prophylaxis for babies, and we don't quite yet know if there's one best. And so really there is a much more, really fleshed out discussion that we're having amongst ourselves as providers, but also with our patients to let them know everything that is available and to have them tell us what also is gonna feel, what they're gonna be most comfortable with. And again, at my breakout today, I'll be diving into this topic a little bit more. These are just the additional questions that are really coming up around breastfeeding. All I'll just say is, as we wait for the data to be published, and thank you to all of you who have been publishing data from your programs, we are also hearing about all the other questions that are rising up. And so I do really hope that if you are at a program that is offering breastfeeding for your women with HIV, that you are tracking some of these questions so that you can help us answer these very common practical concerns that are coming up across the U.S. All right. I'll just spend a little bit of time kind of touching on, one aspect of the long-acting therapy conversation that we sort of started talking about a little bit, but on the panel, but maybe didn't get all the way through. So, there are many, many different protocols out there. I haven't mentioned the Ward 86 protocol that was updated in May, which is wonderful and very thorough. But ultimately, everyone has a slightly different take about which mutations are going to feel, really kind of, that is going to make someone more nervous or less nervous or not nervous at all. And we also know that there's still a lot of unknowns when it comes to low-level viremia. And I will say, just again, because the PBMC genotyping seemed like a very attractive option, there's also a lot we don't know about that. So I would say, please do try your best to get as much of the treatment history as possible, including all those old genotypes, so you can put together a cumulative profile. Yes, it's really attractive to have that, archive available on your test menu, but if you do decide to order it and it's coming back showing you something that you didn't expect, that can happen, right? So we just have to get as much clinical context available to us so that we know how to apply those results if you're going to use them. And I did want to just sort of pull out that there are some data, again, looking specifically at the question around low-level viremia before and after people change to Cabril. So I'm not going to talk too much about the trial data because folks have probably seen, but there were 2 papers published not too long ago. So one, I believe, was from the group at UCSD. That's the middle one there. So they followed about 144 patients, all who were on who had suppression, under 200 at the time that they transitioned to Cabril. And you can see there that persistent low-level viremia before the switch was actually found to be associated with detectable viremia after switch. And what didn't seem to impact the low-level viremia post-switch were timing of injections, BMI, interestingly enough, the dosing schedule, so the Q1 versus Q2 month, and then also whether, sort of what the pre-switch mutations were, specifically around rilpivirine. This last study, I think, was published by a group in Europe, I want to say, and it was, again, single center. They followed less than 200 patients, but, kind of similar questions and findings. So people who had 1 or more viral load above 50, so their threshold was 50 after the switch, actually, it was found that they were more likely to have detectable viremia in the year prior to the switch. And they did a number of PK measurements, and of the limited number that they did, they actually found that none of them seemed to correlate with this either. So I think there is a lot we do not know still about low-level viremia, and I would say, again, to all the researchers, please don't forget to help us answer this question. All right, so Hep B screening, I think I mentioned this on the panel, and this has come up a lot, but I think just really, let's not forget to remember what the complete triple serologies are, and if you can't find them in the old records, the old paper charts, just do the repeat screening and then offer vaccination to folks that's indicated. This was a group at Mount Sinai in New York that actually did like a quality improvement project. I think they built in sort of reminders or alerts about, don't forget about Hep B for people you're considering Cabril. And they actually found that, just building those reminders actually helped change decisions, right, for people who were being considered for a switch and then ended up actually not getting switched to Cabril because, as it turns out, they had, a cold Hep B or whatnot. So I think this is really exciting. We need to just keep keeping our eye on ultimately, we want to vaccinate everybody. All right, so Hep C treatment interruptions, because I'm getting low on time. For folks who are treating Hep C, just know that treatment interruptions are really, really, really common. They happen for all the reasons that you can probably anticipate. And when we actually looked at our data for our Hep C Warmline calls, we found that about 11% of calls coming to us were specifically around how do I manage someone who's had a treatment interruption for their DAAs. And, the guidelines I heard they're going to get updated, but I don't know if they've been posted quite yet. But the guidelines do have this sort of new kind of flow chart that you can follow depending on where someone is in the course of their DA and like the timing of the interruption, the duration of the interruption. And I'll just say, that was incredibly helpful to see, but it also only really covers a very narrow kind of subset of cases, right? So there's no information on what if someone has a treatment interruption and they're already on their retreatment course. So I think this is a really, really important question that we just need to sort of get more data on so that we know what we should be doing by our patients. And then last question before the Q&A, is how do I start buprenorphine for this person? So just shout out to IAS-USA to really put this on the radar. I think as HIV providers, we are in a very unique position to be, talking about substance use disorders and offering treatment for our patients. And, sort of the theme of this whole conference is options, right? We know that there are multiple options for medications for opioid use disorder. We know there are multiple options for buprenorphine. And ultimately, it's going to be what is going to work best for this patient, right? So here's a screenshot of a resource that was put out from some folks at the San Francisco Department of Public Health. Really walks you through, comparing and contrasting the low or microdose inductions, the traditional home starts with the 4 milligrams, and the higher or macrodosing for bupe. So thank you all. Bupe saves lives. Shout out to my team, Christina, if you're still here. I'd love to call you out, and Ron.
Great, thank you. That was a whirlwind of a lot of really controversial areas. So please go. Start, Phil Bulldog.
Thank you. So Carolyn, on our FMOV service Sunday morning, we had a patient deliver who was high risk, and through conversations earlier, the pharmacy had assured us that we had triple therapy available for the baby with raltegravir, zidovudine, and lamivudine. And I just got a message this morning that actually they don't have raltegravir liquid commercially available to send the baby home with, so they're switching to nevirapine. Is this something that other people have encountered, that even though raltegravir is in the guidelines now as an option for these high-risk babies, that it's actually not available? They said they can compound it, but it's only stable for 30 minutes, so it's only available to inpatients. So I don't know if anyone in the audience or yourself has any experience with infant raltegravir and getting it somehow.
Well, I'm shaking my head at the compounding, not that we haven't heard it, but yeah, it is an issue, and it's granules, right? Several of our clinical pharmacists are not comfortable with the compounding. So I think if nevirapine is an option, at least even if it's temporary, right, for the duration that the person or the baby's going to be on triples, it might be, you might consider switching that in.
Okay. Yeah, I mean, we've had drug rash and
liver
injury on other infants, so I really wanted to use that raltegravir, but...
No, I know. At ANAC, I just said, why are we still prescribing meds to babies that we haven't prescribed to adults in 20 years?
All right, thank you.
Great, thank you. We have several questions about PrEP. I'm going to leave those till after the next talk. I'll put them in the cards for the next talk so we can make sure we get to them or tell our speaker in advance. So a couple of questions about HIV testing. So with this traditional HIV 1-2 differentiation assay for false positive labs that are reflex to NAT, since their labs switched to doing this, they've seen more false positives that were either elite controls or immigrants on meds who were really hesitant to discuss the fact that HIV for fear of deportation.
Yeah, no, I mean, thank you so much for sharing that. I mean, I those are my same concerns, which is why I felt, it was really important to talk about the testing challenges that are coming up. And even in the breakout session the other day, someone was like, well, what do you document on your note, right? Like, do you put an ICD-10 diagnosis of HIV? And so we talked through really if you're having questions about what this person's status is, you might not do that until you really have done all the testing that you feel like you need to do to be able to tell this person confidently whether they are or are not living with HIV. And it might take time. I mean, that's the thing. You might have to retest and get more history.
Yeah, I guess people want a little bit more clarification of what you would do. So there's someone who comes in and they seem really low risk. So how do you what do you consider in terms of that false positive diagnosis?
I see. Okay. Well, so if the initial 4th gen was reactive and then the differentiation also came back as indeterminate reactive, I would ask my lab what was the signal to cutoff. So the signal to cutoff isn't like a perfect measure, right? Because there's not like over 20 you can be, know what's real and under, but just I think it gives you another data point. So depending on what the signal to cutoff showed, depending on whether this person had been on PrEP or PEP or had a vaccine or just something, like I just want more information. And then I end up retesting people. And it's not great because like the time between the initial batch of tests and the retest, someone doesn't know what's going on. But I would rather, do the best that I could so that I was just, it's a life-changing experience to tell someone, right? Like one way or the other. So I would retest. The CDC does still, I think, offer Western blots, so that could be available to you as well. And so just really get to know your health department lab because they could offer testing maybe.
Okay, great. And regarding infant feeding, so what do you recommend for infant ART post-delivery for a mother who's been consistently undetectable at less than 20 that wants to breastfeed? It seems like the PEDS ID really pushed for extension of ART for babies breastfeeding for a mom who seems very low risk.
Okay, yeah, great question. So right now as the guidelines are, sort of state, you've got lots of options. You can do nothing, which is I think what many in Europe do, but we're not Europe. So my guess is that most providers here would probably want infants on some kind of ARV prophylaxis. Again, really just you have to talk with the caregivers about all the options and what it entails. I will say that if you do have a baby on ARVs, if it's one ARV versus 3, that's a very different conversation in terms of toxicity monitoring. And then ultimately, both mom and baby are going to be getting a lot of very frequent follow-up with the care teams and a lot of labs. So I think it's really important to communicate that up front, just sort of to like clarify expectations going forward, because this is new to all of us, and we want to make sure that we're doing right by our babies and moms.
Great. Another question is really about PEP, probably non-occupational PEP. Mm-hmm. So thoughts about PEP in pocket, which is PIP. Never heard that before. Are you prescribing it? Do you recommend it? How do you think about that?
I haven't prescribed it only because I don't think it's yet been incorporated in the CDC guidelines, but I think it's amazing. Some folks in the UK and Canada have, I think, incorporated this into their practices and their guidelines. There's a group in Toronto specifically that's been really just trying to say, hey, think about PIP, you can do it. Again, it's like the meds that we're prescribing now as PEP are very safe for the most part, and I think in other settings it's been shown to like high uptake among patients, safe. You just got to do that teaching, and it'd be great if we could in the U.S.
Great. Okay, I don't think I'm leaving these last few questions for our next speaker, so thank you very much. That's been a great presentation.